It is just a huge, huge honor for me to have Dr. Effie Habsha come by my house today. I mean, how lucky am I? She is a prosthodontist practicing in a multidisciplinary practice in Toronto, Canada. She earned her DDS from the University of Toronto. Upon graduation, she completed a one-year general practice residency at Mount Sinai Hospital in Toronto, Ontario. Dr. Habsha received her diploma in prosthodontics and a Master's of Science degree, both from the University of Toronto. She is an adjunct assistant professor at the Department of Dentistry, Eastman Institute for Oral Health at the University of Rochester Medical Center. She has served as an assistant professor at the University of Toronto and currently instructs both as the undergraduate and graduate level in prosthodontics at U of T. Dr. Habsha is professor at George Brown College of Applied Arts and Technology and is on-staff prosthodontist at MedCan Clinic in Toronto. She holds an appointment as staff prosthodontist at Mount Sinai Hospital, where she instructs the dental residents and is involved in various clinical research projects. She is a fellow of the Royal College of Dentists of Canada and is examiner and section head for the oral examination and prosthodontics for the RCDC. She is an associate fellow of the Academy of Prosthodontics and a fellow of the Pierre Fichard Academy, and holds memberships in numerous prosthodontic organizational societies. She lectures both nationally and internationally on various prosthodontic topics and maintains a private practice limited to prosto and implant dentistry in Midtown, Toronto. My God, what do you do? Do you ever sleep? Or
barely.
Are you just on amphetamines all day long trying to get all this done?
Pretty much.
So what's the point of dentistry in Canada when your favorite sport is hockey and just knocking all the teeth out?
Well, it's good for business.
It's good for business?
It makes for good business, so that's where to practice.
So one of the, I wanted to get you on for so many reasons, but you're an expert and lecture around the world on digital dentistry. And where is digital dentistry? And I want to say it in the context of a lot of these kids are scared because they come out of school like $350,000, $500,000 net. Phoenix, Arizona has two dental schools. One is AT still, Mesa, private. Right. The other one's Midwestern, Glendale, private. These kids are paying bank, and they come out of school and they say, I want to be an amazing prosthodontist like you. So where does the technology fit on bleeding edge, too expensive, to leading edge, to it's a return on investment?
I think it's a really good question. I think that in order to kind of keep up with the times, you've got to adopt digital technology, because the key is it's going to make you more productive. It's going to keep you one step ahead of your competition and allow you to do stuff that you can't really do efficiently in conventional dentistry. So I think it's a wonderful adjunct in all levels of dentistry. We've certainly incorporated it in our practice as well, from implant surgery all the way to digital impressions, digital laboratory workflow. So it's really been an adjunct in what we do.
What I enjoyed the most about digital dentistry was, for me, it's just always the magnification. I'll never forget when I took my first oral scan impression.
It's a humbling experience, isn't it?
I thought Stevie Wonder cut the prep, and my assistant said, no, it's probably Ray Charles. And I don't think I've ever looked at a prep scan where you don't go back and touch it again.
Yeah, I mean, it's as I said, it's a very humbling experience to look at that, at your prep on a massive screen. So I think it makes you a better dentist as well. So using that part of digital dentistry, the digital impression per se, allows you to, I think, be a better clinician, and a whole host of other benefits, to your patients and to the practice workflow. So yeah, I mean, when I started doing my digital impressions quite a few years back, I would go back and go, okay, well, maybe we need a bit more clearance here and refine the margins there. You tend to obsess. And certainly when you're designing, if you're doing any chairside milling, the same thing holds true. You kind of want to make your margins perfect and everything perfect. And the technology is there that you can do that now. It's no longer hocus pocus.
Yeah, and even the labs say that, most labs say that their average impression material dentist is running a 6% remake. Right. And their average digital dentist is a 1% remake.
Right. Well, because you can see it as you go. It's not like, I'm doing full arch reconstructions, full mouth rehabilitations using digital impressions. And the nice thing about it is that you can go and, make your impression kind of stitched along so that it's not just a one-time deal where you make that full arch impression and cross your fingers and hope that it works. You can see it as it goes with a digital impression.
By the way, you have the longest resume in all of dentistry. The longest.
I don't know about that.
So, What is name brands? A lot of times they get mad on the show. They say, "Yeah, but you didn't say which impression." Any name brands you like more?
Well, we have. I mean, I'm lucky to be part of a large, multidisciplinary practice. So we actually started off with the E4D scanner, impression system, and then we have the True Definition. Because we weren't getting exactly what we needed with that generation of scanner. So we have the True Definition scanner by 3M, and now we also have the OmniCam by Cerex, so we can do some chairside work, which is really exciting as well.
Man, you have all the big boys.
We do.
E4D in Dallas was bought by Plan Mecca, a monster company.
That's right.
And where are they at in Denmark or?
Somewhere
No, they're
Europe.
in Finland. They're
somewhere,
in Finland.
I was going to say.
And
yeah, so it was good. It was, really revolutionary in terms of doing chairside milling. But it's gone through, as you know, many iterations, and now being the planned scan, it's a lot different. I don't have that system now, but it was good for us as an entry point. But then we've shifted into other scanners as well.
And you like which one do you like the most? The True Definition?
I don't think it's a matter of liking the most or not liking the most. I think they offer different things. Look, it used to be with digital impressions that each company was kind of closed in their own little world, but I think manufacturers and industry has gotten smart where it's more of an open system where, they have STL files that can be sent to labs. So a lot of the scanners are doing a lot of the same things and have, various open platforms. Some have strengths that others don't. I think from a chairside milling, having the opportunity to mill abutments chairside, I think that's really exciting, and that's something that I think the OmniCam and the Cerex system does really well. But I've been very happy with the True Definition scanner as well. I've done a lot of large cases using that scanner. So I think it's a matter of what makes sense in your hands, what relationships you have, what your lab works with. And really, I think in North America, there are pretty much 6 major players, and we have, two in our office, be it the 3M scanner, the iTero, and a few others. PlanScan, Trios, Trios is another
Trios
popular
had
one.
a 3-shape.
3-shape, that's right.
The one out of Denmark.
You know what?
Trios had a 3-shape.
3-shape, yeah.
One of the things that one of the complaints I didn't like about the 3M is some people said, well, you had to use powder.
Right, and that's...
And I always cringe at that because I imagine myself getting a bypass. And I remember the gold standard of bonding was, a blue phosphoric etch and some primer and some bonding agent. And then, but it always had to get faster and faster. And then it came out like Prompto Pomp. And I just thought, when I get a bypass, I don't want the doctor saying, I'm using the Prompto Pop. Yeah. And one extra step of spraying powder is I'd rather just have a doctor that said, I just really want the best.
Right.
And it seems like a lot of people in dentistry, they just are so fast to just cut one little step that, if spraying a little powder gives you a rocky hot better impression, I hope they spray a little powder when they're looking for my prostate cancer. You know what I mean? Or if you're dead set against using powder for whatever reason, then that's not the scanner for you. For me, it hasn't been a big deal. Certainly the Cerex system needed powder originally, now you don't. So, it's one of those things that it's really not a game changer for me, and for, thousands and thousands of other people. It still delivers a very good product, and at the end of the day, that's what you want. You don't want to ever compromise, the integrity of your work, and so it doesn't. You have a very unique practice. Describe your practice. You have multidisciplinary, and you have your own lab, your own digital workflow lab. We do. We've sort of expanded over the years. We've got a number of prosthodontists, some other specialists, endodontists, a couple of periodontists. But what really makes our practice really amazing is the people and sort of the workflow that we built the practice with the idea of having the patient in mind, where it used to be that patients would run in and see this specialist and that specialist and go here for your CT and there for your surgery and there for your prosthodontist, etc. So now it's all under one roof, where we can see a patient comes in, we have a CBCT in our office as well. They can come in, have their scan, have their implant surgery, all the prosthodontic work, and all of the lab work in the same facility. And I think that that's sort of a trend that we're seeing, and we're very lucky to be able to do that and to really have all the tools at our disposal that makes us be the best that we can be. Man,
it's a good place to work.
I would kill to get an online CE course from you. We started the online CE in 2004. Millennials love watching online CE instead of driving to the building.
Right.
And we've got 440 courses coming up on 1 million views.
Okay.
But I am just you talking about that. I would love to see that because it's everybody's there's 3 things everybody's talking about. One's digital, one's implants, one's Invisalign, and those seem to be the newest, biggest, hottest things when we measure clicks and views.
Yeah.
Well,
I mean, the digital technology is kind of starts for the patient experience before they even come into our office. I mean, online presence, social media, all of that starts before they even step foot in your office. And so it doesn't just, it doesn't just occupy one facet, just from the administrative level to the clinical, the laboratory level, and education. I mean, you mentioned education and CE. We built, as part of our practice, a CE center. So we have an education center at
what
the
kind
facility.
Of curriculums, yeah.
Oh, we've got, we try to stay a step above, the competition. I mean, I think when we started off, it was more kind of lecture, basic classroom style stuff. But then we saw, let's do something different and more advanced. So now we really focus on hands-on programs. We're doing digital programs, veneer courses, implant courses, really everything. And we have the capability of, because it's all in a clinic setting as well, we have a couple of large operatories in our office that we stream and it allows us to see the procedure in the clinic directed into our education center.
Your online CE would be the best marketing for that because what a lot of these institutes do is they have like a 3 or 4 day course. They put a 1 hour course to kind of go from just seeing it in a flyer to get to see it for an hour to getting on an airplane.
All our courses are recorded, and so they're available. You have access to it through our website. So,
and what is your website?
www.buildyoursmile.com, and the education is paceeducation.ca.
Can you send me paceeducation.ca? So what will my homies find on Build Your Smile?
So that's our office website.
That's your office
That's our office website. So that sort of shows.
So Build Your Smile is your private office.
Yeah.
And what's the online CE?
And then PACE Education. So that's Prosthodontic Associates Center for Excellence.
PACE.
.ca.
Prosthodontic Associates.
Center for Excellence.
Center for Excellence. Because that's also, the PACE is also the approval.
That's right, yeah.
For ADA or AGD, one of them
does
PACE.
Cuts both ways.
It cuts both ways. That's a great name.
Yeah.
So so these kids come out of school and they want to be great, but they can't learn everything overnight, and they're bombarded by messages. Some say you should learn Invisalign. Some say you should place implants and bone grafts. Some say sleep apnea. Some say be a cosmetic dentist. And she's sitting there. She's 25 years old. She's driving to Aspen Dental for her job, and she's like, where do you think she should begin? Especially if she was trying to pay back $350,000 of student loans.
First of all, I like how you say she, because as you know, in our dental school, I mean, the majority of the graduating class is female. So nice on you to say she. So typically we're going to see a lot more female dentists, but we'll get to that later. But I mean, I guess I can just draw from my own experience where, when I graduated, I wanted to specialize, and I'd spoken to some people, but I was very passionate about pros, and I had the opportunity.
Where did that come from? Was your dad or mom or uncle?
No, I'm the first immigrant family to Toronto.
And where did you guys immigrate from?
From Tel Aviv, from Israel.
Nice.
Yeah. So my dad, I worked at a hardware store, so that's where...
A hardware store.
So I'm used to,
exactly,
screws and drills and all that stuff. So now I do little miniature screws and stuff. But I've always been good with my hands, and my passion really was from my mentor, George Zarb. So he was...
George Zarb.
Yeah.
From the University of Toronto?
From the University of Toronto, that's right. He pretty much, along with Professor Brannemark, put implant dentistry on the map in North America. But that's a whole other story. But so he was my mentor. I worked for him in the summers and just really was passionate about prosthodontics. So when it came time for me to decide my career path, I said, even though Pros is a little bit competitive, I mean, every general dentist does, cosmetic dentistry, if you will. But I said, you know what? Screw that. I want to do what I'm passionate about, so I'm going to go with a specialty that I enjoy rather than something that could make me quick money. And so that was my journey, and I have no regrets. I think I think you need to just be passionate about what you do, and prosthodontics really offers so much in dentistry, really cutting edge, and that's what we've sort of built.
So you can find all that at paceeducation.ca. Paceeducation.ca. If they type in .com, does it have a redirect?
I don't know. Try it.
You should get a redirect on that, because that's a
note to self. Okay.
Yeah. So .cas or get a .co and all. So they can find out all the information to Pace at paceeducation.ca. I got to tell you my one hardware store though, which reminds me of your office. There's only like 2,020 billionaires, and most of them did something really, really simple. And I loved reading autobiographies of billionaires. And one was Thomas Watson Jr. of IBM, and he learned everything from a hardware store. He grew up in a small town.
Okay.
And there were 3 hardware stores, and 2 of them had 1 clerk, and one of them had 2.
Okay.
And whenever he'd go to one of the stores and had 1 clerk in his line, he'd jump on his bicycle and ride across to the store with 2 clerks, and he realized that market share had to do with not number of locations, but by number of reps and services. So when he inherited IBM from his dad, he said, I don't know anything about computers. He basically flunked out of college. He was drunk through his whole college, and he said, all I know is this: if 70% of all the salesmen in the world work for IBM, we'll have 70% of the market. Because nobody knows what a computer is, no one knows how it works. So if 7 out of every 10 people are saying, buy this one, you get that one. And I see that with corporate dentistry, where they just have better hours, they have their better chance of seeing you that day. So if you're all that in a bag of chips, but you can't get me in for 3 days, or 4 days, or next week, and then I call these corporates, or you have a large multi-specialty practice, it's more patient-centered than doctor-centered. I mean, when you're in a group practice, you're covering, look at retail. The business model for retail, going all the way back to New York 300 years ago, was that you had a little garage and lived above it, and you were bankrupted by the next generation, who got 2 garages wide.
Okay.
And the next generation went 4 and 5. So to kill scarcity, they just kept building bigger boxes until there's no scarcity. And so you have far more products and services to sell by having periodontists, prosthodontists,
I think it's about the experience. And I mean, so many of us, people are busy, and you want to have a good experience and an excellent experience, and the customer service that you want to have, the work, and efficiency. So, coming to practice where I'd like to think patients are treated really well from the moment they contact us, and being able to have everything done under one roof, I think is a real benefit. So, there's that boutique feel to the practice, with the ability to kind of offer anything a patient might need. So that's kind of what sets us above. And plus, our individual need to constantly improve what we do. We're all, very driven, just wanting to continue to learn. We're heavily involved in education, and both educating ourselves as well as, educating others. So it just somehow all falls together.
Now, do you place implants, or do you restore? Because a lot of a lot of prosthodontists will tell you that they're afraid to place because they get so many referrals from oral surgeons and periodontists, and they're afraid that if they start placing, they'll only get referrals from general dentists.
It's funny you say that, because that was our dilemma, because we didn't place. When I graduated, I wasn't placing my own implants, but then over time we sort of started to see this need for, patients getting annoyed of having to go to multiple practices, and then we thought, what if we brought in a periodontist, or we placed implants ourselves, and that was really a dilemma. So yes, we did lose our surgical referrals, but what we gained completely surpassed that. So on a personal level, it allowed me to kind of challenge myself, because I get bored. Every few years I get bored professionally, so I need to do more stuff. And so it allows me to, to broaden my horizons, allows me to kind of challenge myself, be better at what I do. so that's a personal fulfillment, but then the patients as well, they have the benefit of, again, having everything done in one facility. So
this is Dentistry Uncensored, and we don't like to talk about anything that anyone agrees on.
Okay.
So let's just start going to the hard-hitting, below-the-belt controversies on Dental Town.
All right.
To screw or cement your implant. There seems to be a war going on Dental Town about whether...
Well, I think our screw-retained people are winning that battle. It used to be historically that prosthodontists, everything was screw-based dentistry. But then industry got involved and said, well, we're going to teach every Joe how to place implants and how to restore implants, I should say. And, the whole shift towards cementation was primarily industry driven, where, hey, just your surgeon can even put the abutments, just prep it like a tooth and just cement it. That was kind of the idea behind that. But we've seen a lot of problems with cement-based restorations. And so the pendulum has swung back to, primarily screw retention. And not that you don't cement retain if you have to, and we're not going to get into the details as to when you cement and screw, but if I have my choice, if I have my preference, and I think most prosthodontists you would speak with would probably recommend screw retention. And you're also seeing industry also following in that with the ASC, the angulated screw, the ability to go in with screws in situations which conventionally would have been cement retained. So I think industry is also catching on.
I can prove statistically that this next question is the most controversial on implant dentistry.
Okay.
It seems like everyone on earth who has placed over 1,000 implants says that a surgical guide is like training wheels. Grow up, learn how to make a flap, you need to see the bone, do it right, be a surgeon, or go home. And then everyone who's done under 100 says, oh, no, you want a surgical guide. So there's these two camps, and it seems like everyone who's done 1,000, 5,000, 10,000 thinks it's training wheels, grow up and be a surgeon.
Right.
And everybody 100 under is like, no, I just want to make it soft and pretty and bleaching, bonding, veneers, surgical guide. I don't want to see blood.
Well, I mean, I'll tell you.
Where do you fit on surgical guide? If you placed 100 first molars,
yes.
If you placed 100 mandibular first molars, what percent of the time would you use a surgical guide?
I use a surgical guide almost all the time, and I'll tell you why. Because I think you get the precision that you can't get otherwise. So I know exactly where I am surgically. And I think that, again, the patient experience is so much better. If you're placing, multiple implants, 6 implants, would you rather, have it done in a flapless guided fashion or have a flap raised from, ear to ear and the whole post-operative issues with that? So I think you have to believe in digital technology and believe in the accuracy of it to feel comfortable doing it. And we've placed thousands of implants in a guided surgical fashion. I'll tell you, in the beginning, I mean, we started with the original Nobel guide over 10 years ago, and those guides didn't fit that well at the time. We had a lot of adjustments, so you kind of would wonder about, the detail and the accuracy. And if you're using this, how accurate is it? But again, the technology has improved so much that now these guides fit beautifully.
Which guide are you using now?
So we use Nobel Clinician. We use Simplant. So, the Simplant with Materialize that makes the guides. But, now primarily Nobel Clinician.
And so you're placing
We've got
Nobel.
Multiple systems in our office as well.
Yeah, are you mostly placing Nobel implants?
Nobel, we've placed Zimmer Biomed as well. We're placing Southern implants as well, which are really neat. So Southern, yeah.
Man, it's like every month I hear of a new implant company.
Well, they're an interesting company because they have an interesting product where there's an implant called a coaxis implant, just as an example, where the body of the implant has a different access, but kind of like a zygomatic implant, but there's an angled head. So it allows you to do screw retained restorations in situations where you would normally have to be cemented because of the design of the implants. Anyway, they've got some nice products. Fat big implants, wide implants for immediate implant molar site. So, so it's not like we just select these implants just cause. It's because they offer different solutions for different situations. So, yeah.
So, what I think is amusing is so many kids are afraid to place an implant, but they're doing procedures that I think require more surgery, like removing a wisdom tooth.
Oh, yeah.
Do you agree that anybody that can remove an impacted wisdom tooth can place an implant, or?
I think with the proper training, I mean, we do, never mind impacted wisdom, I mean, surgically we're trained to do that. I think if you have the proper training, not just a fly-by-night course, a weekend course, weekend warrior course, and you do it. I think if you have proper mentors, proper training, then you have the clinical skills to do it. We place little tiny posts in teeth as well. So, I mean, we have the precision, we have the skills. Why can't you place an implant in a massive amount of bone?
So are you teaching hands-on over-the-shoulder implant placement in Toronto?
Yeah, we have programs that do, hands-on.
Because what do you actually mean by digital workflow? I mean, what is digital workflow? Does that mean that it's going to be a digital scan, a CAD/CAM mill? What CAD/CAM are you using? Are you going to chair-side mill that? Or are you going to have, how many laboratory technicians do you have in your office?
We have 10 lab techs, yeah.
10 lab techs.
So we have a digital lab. Our lab also has sort of expanded. So again, moving away or it's just about keeping up with the latest and keeping up with the times, really. So the conventional way of doing things, I think we found that if you're going to keep up with the times, I mean, digital is the way to go. I think we see that with labs in the U.S. a lot of, and in Canada, the little mom and pop shops have closed down or were bought out by larger labs because you can't keep up with that, with the technology. So again, I think, the lab has been well ahead of us, of the clinical dentist for many years. I mean, they've been doing things in a digital fashion, milling crowns and whatnot for quite a long time. And only now, dentists are getting more into the digital workflow. So in our office, when I say, the digital workflow, it really encompasses everything we do. So at the administrative level, but we're not even going to worry about that, the diagnostic level, having digital radiography, CBCT on hand, digital occlusal analysis system, like really we incorporate it almost routinely. And then if any patient that's going to have implant surgery as well, we have, as I said, a CBCT in our office so we can scan them. Our surgeries are done in a guided fashion most of the time. And then our prosthodontic work as well. So digital impressions, I will tell you that I'm not doing a digital scan for every single patient that comes in, but there has been a shift for me. I mean, I've been doing it for quite a few years, that now, if I'm doing a single unit implant restoration, I don't want to have an impression. Just stick a scan body on there and make an impression. It's just a digital impression. It's so much cleaner, so much neater. So to answer your question, I mean, what do we do in our office? I think pretty much every aspect of dentistry that we offer, and then that also extends into the lab. So once a case is sent to the lab, we're milling crowns, we're milling full arch restorations, implant-based restorations, single units, both tooth-borne and implant-based. So it's really part of our workflow. And then, of course, we have our laboratory technicians that will, refine things or if need be.
I'm talking about, I think in my 30 years from 87 to 2017, of the 9 specialties, the one that changed the most was periodontics. I mean, I saw little changes in endo and pedo and, but periodontics, I mean, it went from all these surgeries trying to save all these teeth and furcation to just curing everything with titanium, just pulling everything out titanium. But it's tough for these little kids because you're podcasting to millennials, and their oral surgeon is saying, yank it out and put titanium. The periodontist is saying, save the tooth, do a molar surgery. And then the epidemiologists are saying that all these implant companies say they have like a 99.99999% success rate, and they're showing 20% periimplantitis at 60 months, at 5 years. So there's a lot of misinformation.
Mixed messages.
So how do you treatment planner to pull or save the molar, And then how do you tell a patient that has a 99% success rate when the periodontists are seeing a 20% periimplantitis rate?
Well, I think that's a very good question. It's a very good point. I think you have to be a good diagnostician and figure out, effectiveness of a particular treatment. So if you're going to look at the single molar, just for example, so if you have a case where, in order to save the tooth, the patient would require crown lengthening, endo, and a crown and a post and corner crown. By the time you add up all those costs, you're way more cost effective and more predictable, in my opinion, placing an implant. So I think every case is very specific, and of course not every compromised tooth. I mean, we still try to save teeth, absolutely. We know there are certain definitely benefits, even from a soft, cosmetic standpoint, where it's advantageous to do that. So I think it's really a case by case basis. But I think that the days of saying that implant dentistry is an implant, once it's placed for life, which is what we kind of used to say. I don't think you can really say that anymore because, of course, depending on how old the patient is, but I think we are seeing some challenges with, periimplantitis, et cetera. So it's kind of a balance that you have to strike. But I think the key of it is just good diagnosis and having the capability of not placing implants in compromised sites, or having the knowledge to understand, if there is insufficient bone volume, to generate the bone before you do it. So I think that's where people run into problem, where you want to be the cowboy and take a tooth out, put an implant in, not having any regard for biology. That's a lot of, it's quite industry driven sometimes, I hate to say. I think we sometimes need to take a step back and say, okay, is what I'm doing making sense? And just to give you an example, immediate load. I mean, you can talk about that, and it absolutely works, and it works really well in the right application. So if you have a case where, you place an implant and the patient wants a restoration right away, you can't do that for every patient. And sometimes you go in with the best intentions, but if the biology doesn't permit it, then don't do it. And I think that, maybe young people or maybe that's where people may run into problems, where you just don't respect the biology enough, I think.
Yeah, I think the hardest lesson every single millennial out there listening will have to learn the hard way is they don't want to do something, and Grandpa talks her into doing it. And she has this pit in her stomach the whole time. She does it anyway, then it fails like she knew it would. And then she drives all the way home wondering, why did I do that?
Right.
And old people have a way of manipulating young people to get what they want done. And every time I ever really screwed up is some grandpa with a liver spot talked me into doing something that I shouldn't have done.
That's true. You do have a point. I mean, it's hard to say no sometimes, especially when the patient dictates. And I had a case like this just yesterday. I had or last week a referral. A dentist referred a patient to me. She said to the patient that the patient would require crown lengthening before placing the crowns, and the patient didn't want to hear anything of it. She said, Effie, please help me out. She's really, pressuring me. She doesn't want to do the crown lengthening. And I basically said to her, I'm happy to see her, but if the case needs crown lengthening, she's going to have crown lengthening. It's not up for discussion. So I can see, and this was a much younger dentist that was, didn't have as much experience or confidence, I guess. And I can see I can see your point. But you just have to stand your ground and don't go with your gut, basically.
So every periodontist has told me for 30 years that if he has 25 people that refer to him, 5 people send him 90% of his crown lengthening procedures, and the other 20 or 5%.
Right.
Why do you think that's so like that? Why do you think some dentists, a small minority, probably the 80-20 rule, why do you think 20% of the dentists do 80% of the crown lengthenings?
20% of the dentists do 80.
Or have
student loans? I don't know. I mean, taking on more than they can chew. Is that what you're referring to?
No, I just for all 30 years, every periodontist I know says, almost all my crown lengthening patients referred to me for crown lengthening come from like 3 or 4 or 5 dentists, and the other 20 never send me one ever.
Right.
They've just always seen that. for decade after decade after decade?
I guess people want to keep things in-house. I can't speak to that, but as a prosthodontist, our referral patterns, I mean, we have some good referrals, but what we find is that we get, single referrals from a lot of people kind of thing. There isn't that consistency because the truth of the matter is, it's economy. A lot of people want to keep stuff in-house, and especially with something like prosthodontics. Why would I send it to a prosthodontist?
So I want to tell you the biggest prosthodontic complaint and in the CE market, the continuing education market. The labs say that 96 out of 100 crowns are sent in one unit at a time. And then when you go to all the major meetings, all the CDA in the Greater New York and Toronto and all the big ones, all the prosthodontic cases are all on 4 full mouth rehab. And all my millennials are like, dude, I've never done a full mouth rehab in my life. I'm trying to learn my basics. I'm trying to learn how to do a filling and a crown. How could you step it down and just give her some tips on just a first molar crown? And when you look at insurance data in the States, you look at like 100 million claims, you look at the 32 teeth, all the dentistry spikes on those 4 6-year molars. I mean, they get all the root canals, fillings, crowns, extractions, replacement. So can you give her any tips on just a single unit first molar crown to be a better
clinician. Doing that? The tips would be isolation, respect the soft tissue, use the appropriate burrs, and I'd like to think in dentistry or in dental school, one would be quite proficient in doing a single unit crown. I think the challenge is more of the large cases that you see where people bite off more than they can chew and get really lost in restoring vertical dimension or opening up the vertical without really knowing what they're doing. So I think that's where people have to really be careful and take the appropriate courses and do kind of the due diligence before you embark on something that's too extensive. But
now I want to ask you a religious question. My friends in Phoenix that are ear, nose, and throats, some of them call themselves rhinologists.
Okay.
They see patients that thought they had allergies for 10, 20 years, and it's a leaking root canal into the first molar. It's a leaking sinus. Somebody did a bone pack, a sinus lift. And when I talk to my rhinologist homies, they're like, "Hey, dude, you had a elephant tusk, bicuspid in front of it, and a molar behind it. Stay on your teeth, file down your enamel." But see, we're dentists, so we worship the god of odontology. So we don't blink at doing a sinus lift and throwing, a grenade and dead bone and titanium and paper clips and anything we got. And back to that CBCT, those rhinologists are telling me that anybody who has a sinus infection or allergies, who has a root canal and going into the sinus, it needs to be examined by a CBCT or a scope, something, because they just see so many misdiagnoses. Because once you take that nerve out, you don't feel pain.
Right.
So you just leak into there for 20 years. So do you think if you were a rhinologist, you would worship the god of sinus and file down the 2 teeth? Or do you think you're biased, since you went to stomatology school, that you're going to save the teeth no matter how?
That's a good point. I mean,
because I feel people are shamed when they do 3-unit bridges.
Yeah.
I feel people in lecture halls, I mean, they're literally shamed. I mean, I mean, they are. It's like you're a bad person.
Yeah.
For filing down a tooth.
Yeah. No, I mean, I think in certain situations, of course, if it makes sense, then of course, conventional crown and bridge. I had a case a couple of weeks ago where we were looking to redo a patient's full mouth rehabilitation, And one of the sites, she had a 6-unit, an anterior 6-unit bridge, and she had some missing molars. So we scanned her because the idea was if we can place implants in the anterior maxilla and then just have independent units and, restore her that way, that maybe it would make more sense. But after looking at the scan, the amount of grafting we would have to do, it would just obliterate kind of any sort of aesthetic soft tissue response. So we said, no, this is not an implant case. We're going to keep the prep teeth and keep it a conventional case. So to your point of if there's, a sinus lift situation where it's risky, or, if there's a contraindication to a sinus, I don't do sinus lifts myself. I refer that to my oral surgeon, the periodontist, but, you have to know what the contraindications are. If it's someone that potentially, suffers or has sinus issues, maybe you avoid it in that patient and do your 3-unit bridge, if that makes sense. But I will have to say that I do try to preserve my teeth, and if I can keep, teeth, if I can avoid a 3-unit bridge if I had to, then that's my preference, of course. But it's not so absolute.
It's very different treatment planning on a short, fat, bald grandpa like me than a beautiful woman like you. If you had to, what would be more predictable for replacing an anterior tooth on a beautiful woman who shows her teeth when she smiles? A 3-unit bridge or an implant and a crown?
I think it depends on what your starting point. I think that if you have a beautiful foundation, or if you build up your foundation to an appropriate one, then I would like to see an implant there, because over time the bridge isn't going to stand the test of time, but you have to see where your starting point is. And again, the key is to be able to diagnose and to treatment plan properly. And that's where looking at the pink, not just the white, looking at your gingival contours, looking at the aesthetics of the patient, looking at the smile line, all of that falls into play when making the decision. So I think it really depends on what you're starting with.
Okay, and what is your go-to crown on central incisor, first molar?
Conventional in terms of material?
Yeah.
I like lithium disilicate. I like my Emax crowns still in the anterior. Molars, we're going with full contour zirconia crowns with some buccal cut back if we need it, just for aesthetics. But the zirconias are so beautiful these days, or are getting, I shouldn't say so beautiful, but we can use them in a lot more applications than,
And what would you cement or bond each of those with?
The resin cement. So, we use 3M products in our practice. We use Kerr products, but 3M resin cement.
Did you, when you walked out of dental school, did you think you'd witness the extinction of the PFM? I mean, it kind of went the way that I didn't even see it coming.
No, I mean, it really has. And I look at my own practice. I mean, not that there's anything wrong with the PFM, but we have such beautiful materials these days that work. So yeah, it's a constant evolution, and as I always say, the only constant in life and in dentistry is change, really, and you've got to keep up with the times.
So on the other question you're asking is, do you pack a cord or do you trench with a laser?
Another very good question. So I've evolved as well in my practice, and some of it has to do with digital dentistry. So started off doing, for impressions, a double cord technique. And then I moved to retraction paste for a number of reasons. And retraction paste works really, really well. Something like Expicil I use. And that, we kind of threw away, we threw away retraction cord for quite a few years. And then when I came back to making digital impressions, when I started doing that, I thought, well, I kind of need to push that margin out again, because you don't have with impression material, the compression of the tissues. So it all has to be visual or visualized. So I've gone back to using cord, and now I'm kind of in between. So I'll use cord, maybe cord with a layer of paste on top of it as well. And of course a laser if you need it. So it's sort of, I think I'm using more cord now than I did when I was doing just conventional impressions. But the pendulum has sort of swung for me as well. So I think both, and depending on the situation. But retraction paste works really well in my hands as well.
If you did 100 incisors,
okay,
and 100 molars, how many of those, what percent of those would be same-day crowns?
Ooh, I'll be honest, not that many yet. I'd be more inclined in a molar crown. I haven't yet mastered kind of getting ideal and,
Right.
aesthetics. It's not to say it can't be done, but I tell it like it is. So I still have my lab make me my anterior crowns.
And do you, as a prosthodontist, a highly decorated prosthodontist, is there any room left for the Maryland Bridge, or is that
Sure,
another
yeah.
dinosaur?
Yeah, no, there absolutely is. If you have no room for an implant, or if the cost of getting an implant, not financial, but building up bone to do an implant is too great or it's too invasive, then a resin bonded bridge works quite well.
And what do you think is are there any differences, do you think, practicing in Canada than the United States?
I don't know. I haven't practiced in the United States.
I just assume you guys are sitting up there in the loft, looking down at all the hillbillies that live down here, and thinking, "Oh my God, what a crazy country."
No, I think we're so similar. I think there's so many similarities. Our meetings are combined. We attend your meetings, and you come to ours, and I think to me it seems pretty similar.
It does seem like they're much more nicer and cordial and respectful. I mean,
I don't know, you're pretty nice. So.
Well, I'm from Kansas. That's one of the few good sides. Back to shaming, okay?
Okay.
Because they are. I mean, a lot of people, they feel bad on Dental Town. So they did a 3-unit bridge when people are calling them a hack, and they hack down 2 teeth. And I'm like, dude, you threw a grenade in the sinus with a dead cow. I mean, there's religions that are even against that.
Yes, that is true.
That is true. Same thing with the triple tray. That it's just too easy and too shortcut to say triple tray. When does she can get by on a triple tray, and when does she have to do full arch? And further, when does she need a face bow transfer?
I love my triple tray if it makes sense to use it. So I usually like to have posterior stops. So if I'm doing a first molar, hell, I'll use a triple tray for sure. I mean, it's just the same way as a digital impression as well. You don't have to do a whole arch; you could just do the quadrant. So yes, I do use a triple tray. I think there are a lot of benefits in terms of using it in certain cases where you've got 1 or 2 units. I have no hesitation using a triple tray.
But you want a posterior top?
I generally like to have that, so there's
So if it was 2 molars. And
you can still do it. We use a very stiff impression material. I like to use a polyether, so it's quite rigid. Yeah, Improgum.
That's my go-to.
We use it for everything, crown and bridge, implant dentistry, like everything. So it's nice and stiff as well. So I will use it for 2 units as long as I have enough. So if I have like a first and second molar, I could generally use it. It's ideal to have a posterior stop as well. Face bow transfer, anytime I'm reestablishing the occlusal vertical dimension, so certainly not for my 1 or 2 unit cases or where I have a stable occlusion where I'm not really altering the vertical dimension. Of course, any complete denture case as well is when I'd use a face bow transfer.
What I do on dentures is I hire a limo to drive them to the
refer
Denture World Clinic. It's like, you just want a free limo ride all the way to Denture World. I'd rather just give my license and work. That's the reason I got to do
I love my dentures.
Do you really love your dentures?
I love making dentures. Sure, I'm a prosthodontist.
Yeah.
But we're seeing a lot less complete denture making because implant-based dentistry is so prevalent. And in Canada, we have denturists.
Actually, that's an interesting stat. I just saw some good data on that. When I got out of school 30 years ago, they had estimated the disappearance of the denture.
No.
And it has been growing robustly, and it's been growing. People don't like to talk about it because it sounds racist, but because of immigration.
Yeah.
And the United States gets 1 million legal immigrants a year, and probably that many illegal. But like my last denture patient, it was a family snuck in from Bosnia. Mm-hmm. The one before that was from I think Herzegovina during that Balkan thing. And so actually
No,
total units of dentures
absolutely
keeps going up.
Yeah, and if you read the statistics, like even the prosthodontic journals, etc., we are seeing an increase in the rate of edentulosum, and that's even though people are hanging on to their teeth longer, the demographic, the aging population is increasing. So just by sheer volume of patients, you're going to see a lot of edentulous patients. The reason I said we don't see a lot of complete dentures is that in Toronto or in Ontario, we have denturists that have really done are making conventional dentures, but we still see our complete denture patients, absolutely, and or the edentulous patients. And I think the young dentists out there shouldn't be afraid of complete dentures because they are going to be seeing them. So, edentulism is not going away.
Yeah, and there's some of the best full mouth before and after pictures I've ever seen were with dentures. I mean, little girls that don't have any money lost all their teeth from meth or drugs or decay, and they
have the flexibility for sure.
That's been a great thing about
transform lives for sure.
Yeah. Is corporate dentistry having a big impact in Canada?
I think so. I don't, to be honest, I'm not that well versed in the topic. I think it's probably a little bit bigger in the U.S., but we do have our corporate dental corporations that are buying out the smaller ones. Not so much yet on a specialty level, but it is changing the face of dentistry for sure.
It's amazing because as Clear Choice spreads around the country, they do so much amazing advertising on All in Four. I can't believe the first one that opened here in Phoenix. The questions that Grandma started asking me about All in Four just went through the roof. My buddy Tom he quadrupled how many he was placing himself. It's amazing how when a big player like that comes in,
it's great for business because they do all the advertising and the patients come to ask us questions. So it's great. It puts the awareness out there.
I'm going to ask you, you're so sweet to be spending so much time with me. I've only got you for 5 more minutes. One of the biggest controversials they ask on Dental Town is they always come out of school, every generation since the Flintstones, that they didn't learn enough in dental school, they didn't learn implant, And I always tell them, I can't imagine being a dean taking 100 kids off the playground and turning them loose with a license. So I think the dental schools do a phenomenal job. But when they're trying to go learn occlusion, they say that if they want to learn about pediatric dentistry, they can go to any course. If they want to learn about endodontics, they can go to any endo course. But when you start studying occlusion, it's almost like you got to pick a
religion
camp or a religion first. And they're like, do you have to pick a religion first? And quite specifically, it's like neuromuscular or CR or things like that. What are they supposed to think about?
Well, with occlusion, you're right. I chose the safe road. I became a prosthodontist, so I had my training in dental school. And there's a lot of kind of mystique around occlusion. And I don't know. The way I was trained, and George Zarb didn't have this philosophy on one camp versus another, Pankey or whatever institute. So I'm not really very well versed in what they offer. But for me, it comes into play when you establish your occlusion. If you're starting from scratch and doing a full mouth rehabilitation, using your Facebook transfer, doing a proper diagnostic wax up, transferring that to your provisional restorations and allowing the patient to function with it. And if you have, if you're restoring both arches, then you can plan it, either in group function or in canine guidance. And then using your provisionals as your template for the basis of your restoration. So you're speaking to the wrong person about a religion of occlusion, which camp to go to personally.
That's my tip for young kids when they're doing single unit crown and bridge. When the lab sends you back reduction coping, you know what that means? It means you took the final impression before you did your temporary. Work everything out with your temporary. After you get done prepping it, make your temporary. If you can't see the margin on the temporary, it doesn't exist on the tooth. And when you're adjusting your temporary and you go all the way through it, you
need to do more reduction.
You need to do more reduction, and
use your existing occlusal scheme. If you're not restoring your vertical dimension, you use the existing occlusal scheme.
Last question. How would you recommend she ramps herself up as a leader? She's going into a practice. She gets out of school 25. She's in there working with a bunch of ladies who have been there. They're all grandmas. The doctor is 70 years old, and she wants to buy that practice in 2 years. How did you ramp up your leadership? Did you do that reading? How did you become a faster leader at a younger age?
I think you have to look at the people, surround yourself with good people. And I've always been very fortunate to have really good people, really good mentors in my professional career. And so I've had good mentors. I have good mentors. I continue to learn from them. And I think that for a young clinician, go out and find someone that you admire, that you can relate to somehow. That's why I founded, Women in Dentistry Study Group, because for so many young women coming out of dental school, it's a bit intimidating going to these meetings where you see a bunch of, middle-aged...
Website on that? Women? Is there a website on that? Women?
Well, we're actually... Believe it or not, that's on my agenda to do. So my group is PA's Women in Dentistry. We do have a website. We have a domain name. We just have to populate it. So we founded it about 7 years ago. I have a really nice group of women. We have an annual symposium. We have a quarterly newsletter, and the idea behind it is really to mentor the younger female, or not even younger ones, but just, as women, we have some commonalities, but it's not fluffy. It's still about, the best education, the best that we can offer our patients, but learning, not even learning, but networking with people that you're similar with. So with other women that challenge, have the challenges of life and children and work and whatever, I look to my mentors, but unfortunately, there weren't that many female mentors for me to look for. And I think that establishing something like the Women in Dentistry is really nice for the younger women that do graduate, because they see other people in the same sort of life circumstances and aspire to maybe be like that. I mean, it's the biggest compliment and the biggest honor to have some of my residents in grad pros, who are incidentally, I think, all female, with the exception of one who just graduated, the male. But, it's nice to kind of see them, and they'll say, "Oh, Dr. Habsha, I want to be like you one day." And it's very flattering, it's very humbling, but it's nice that they can see what the potential is. It's no longer, it's still a male-dominated world, but we're slowly, chipping away. And I think it just has to be with merit. I don't want to achieve anything just because I'm a female. I want to achieve it. And by the way, I'm a female. And if I can, impart a little bit of wisdom on a younger grad, then I'm happy to do so.
They do have so many challenges I've had one in this front room crying because she came out and set up a nice dental office for 10 years. Her husband made half as much money that got transferred to another city. And he said, "Come on, pack up, we're going." And she's like, it's like, what I mean?
It's not so simple.
His ego.
Yeah, no, it's not.
And he told me
so
that it bothered him that his wife made twice as much money as he did. And I said, "Well, just don't think about that while you're vacuuming."
He needs to get over it.
Yeah, I know, it's tough. And I saw it with my own mother. I love my mom to death, but she used to put my sisters in dresses, and they couldn't go in the river, and she'd put me in blue jeans, and I could go swim. We lived right next to the Arkansas River, and the river was at least as wide as a 4-lane street, and they weren't allowed to go 10 feet to the edge, and I could swim across it. And I couldn't figure that one out when I was 10.
Times are changing for sure. I mean, we see women in leadership positions. I mean, there's so much... I'm so lucky to be living in a day and age where really the sky's the limit for me personally. And I won't let anything stop me if I want to achieve something, and I don't think gender really has to. I think we have a lot more obstacles sometimes. I think chauvinism is still, you still see it. But, do the best you can, be the best that you can be, and that's my piece of advice.
Last question, I'll let you go. You've been so sweet to come by, and she flies into Phoenix for more important business, and stops right here first. Last question, I see this debate, it sounds silly, but it's true.
Yes.
Back to that leadership image. Some of them think that they should be wearing a dress with a lab coat. Other ones like blood and guts and just want to wear scrubs and Asics tennis shoes and mix it up. What
you mean practicing dentistry?
Yeah, practicing. I mean, some women want to be in
like
tennis
sexy
shoes.
when you practice.
Well, no, they want to be in tennis
Yeah.
shoes, planted in scrubs, and just feel like you're going to the gym. But then other women think, well, if I'm going to carry myself and present this treatment of this implant case, maybe I should come in wearing a dress, high heels, and a lab coat.
Hell no. I mean, for me, I am who I am. I go to work in my scrubs and my ponytail and get in there, and I don't want patient stuff on my clothes. So I wear scrubs, and I what I have to say comes across more as the way I appear to patients. I think that, I think the confidence that you carry is more than your outfit. And then when I go to conferences, I dress like a girl. So it's, it's all good. But you do raise a good point. I mean, I have a conversation, a friend of mine who's a prosthodontist who wears a suit and tie, or shirt and tie, and a lab coat. And I said, get over it. Put on scrubs. It's a lot, infection. He goes, no. He practices in West Palm. So it's more like, no,
West
I'm
Palm,
wearing a suit, and wearing a tie, and that's great. But I mean, I'm all for, I wear scrubs.
It's true. You only see that in West Palm. They had probably retired from New York and New Jersey.
Yeah, so maybe that's the
only
deal
restaurants I've ever been kicked out of, or not entered in my life, they were all in Manhattan. I'm sorry, sir, those shoes. I'm like, are you out of your mind? Really, my shoe? And they're like, no, go home and change them. I go, there's nothing I can change into.
I do have nice shoes, but I wear sneakers to the office, so it's all about comfort and
it's such a different culture. Like here in Arizona, when it's 118 degrees,
I love it. Yeah,
people don't. It's a very different dress code than Connecticut.
Yeah,
or New Hampshire.
But
hey, I'm your biggest fan. I was so honored that you came by.
I'm so honored and humbled to be speaking to the Howard Farran.
Oh
it's
my
pretty
God.
Amazing.
And
to your
I hope you
homies,
make this
is
an
it?
online C-course. I really do.
Well, let's
I
talk.
really
Have your
do.
people talk to my people.
All right, we'll do it.
We'll make it happen.
Effie, thank you so much for coming by.
Thank you so much, Howard. I appreciate it.
All right.